We're now over 200 attendees for this event, which is the highest participation we've had for a Paragon virtual event. People continue to join, but I'm going to go ahead and get started. Thank you for joining us today. My name is Brian Blaze. I am the president of Paragon Health Institute. You can find Paragon's research and policy work at our website, paragoninstitute.org. Today, I am joined by two of my excellent colleagues, Ryan Long and Elle Manera, and we're going to discuss the One Big Beautiful Bill and what to expect with implementation. Ryan is Paragon's Director of Congressional Relations and a Senior Research Fellow, and Elle is our Program Manager and our go-to for just about everything in the organization. I'm going to start today with a brief presentation of the health provisions in the legislation, and then we're going to have a discussion and answer as many of your questions as possible. If you have a question that you'd like us to tackle, please use the Q&A feature at the bottom of your Zoom screen. First, I'd like to say a word of thanks. As clear from the list of participants, many of you worked long hours, late nights, and under extremely tight time constraints to get this bill across the finish line. So thank you and congratulations for your efforts. The One Big Beautiful Bill contained 33 distinct healthcare provisions. While this wasn't primarily a healthcare bill, it is the most consequential healthcare legislation since the Affordable Care Act, and it's the most conservative health policy reform in at least a generation. There are four pillars of its health policy provisions. First, common sense work and community engagement requirements for able-bodied working age adults enrolled through the Obamacare Medicaid expansion. Second, major program integrity reforms across both Medicaid and the ACA to stop ineligible and duplicate enrollment and limit wasteful expenditures. Third, a crackdown of Medicaid money laundering schemes, particularly provider taxes and state-directed payments. Fourth, limiting Medicaid and ACA benefits to citizens and lawful residents. These reforms target waste, fraud, and abuse while protecting the truly vulnerable. Overall, the Congressional Budget Office projects that the health policy provisions will mean $1.2 trillion in federal savings over the next decade, crucially important for putting our nation's health entitlement programs on a more sustainable trajectory. Paragon commissioned a public opinion poll to test voter support for the major reforms in advance of the bill's passage. The results and question wording are posted on our website. We also have a one-pager debunking the myth that the bill's Medicaid reforms are unpopular. It turns out that they are extremely popular when people are asked about specifics. For general policy direction, 2 of 3 voters agree with the statement that, quote, Congress needs to take a hard look at all federal health care programs to ensure taxpayer dollars are spent wisely. Weeding out waste, fraud, and abuse would save billions and help safeguard these vital programs so they are available for those who need them now and in the future. On the next slide, it shows the growth in the Medicaid program during the Biden administration. The lower line shows the federal Medicaid spending baseline at the start of the Biden administration. The top blue line shows it at the end. From 2025 to 2034, the baseline soared $1.3 trillion. The orange line shows the effect of the One Big Beautiful Bill on federal Medicaid spending. You can see that spending increases year over year and spending stays above the pre-Biden baseline until 2031. Under the Biden administration, Medicaid spending surged. That spike is largely explained by 2 factors. First, a substantial increase in ineligible enrollees. Millions of people were allowed to stay on Medicaid without proper checks, many of whom were already covered by other programs. And second, a substantial expansion of state Medicaid money laundering, where states game the federal matching formula using provider taxes and then make inflated payments to large hospital systems. Let's turn to the community engagement requirements. It's important to stress that these requirements apply only to able-bodied working-age adults enrolled through Obamacare's expansion who don't have dependents under age 14. That's a very specific population. And the requirement is modest, just 80 hours per month, which can include employment, education, job training, or volunteering. Work is good for people. It improves physical and mental health, builds community, and leads to upward mobility. And the federal government has a particular interest in this population because it pays 90% of the cost for Obamacare expansion adults. Technology has advanced significantly since Arkansas implemented its work requirements in 2018. Today, we have better tools to ensure that enrollees can meet these requirements without burdensome red tape. CBO estimates that roughly half of the projected coverage loss from this bill will come from this requirement. But I strongly believe CBO is substantially overestimating the loss. There are major incentives for enrollees and for brokers, insurers, and providers to ensure that eligible people remain enrolled. In our survey, we asked voters, do you support or oppose requiring able-bodied adult Medicaid recipients to work in order for them to continue receiving Medicaid benefits? This is an 80-20 issue in the eyes of voters, with 80% of Americans supporting Medicaid work requirements. The One Big Beautiful Bill includes major program integrity provisions for both Medicaid and the ACA. For Medicaid, it requires twice-a-year eligibility checks for able-bodied expansion adults. That's critical because income among low-income individuals fluctuates frequently. People move out of eligibility regularly. We need regular checks to ensure the program is serving those who truly qualify. The scale of the duplication problem is staggering. CMS recently identified nearly 3 million people enrolled in multiple state Medicaid programs or in a Medicaid program and a subsidized exchange plan, costing taxpayers $14 billion annually. The OBBB largely undoes Biden ACA administration policies that exacerbated improper enrollment and enabled fraud rings that enrolled people without their knowledge. Paragon research estimates that 6.4 million people are improperly enrolled in fully subsidized ACA coverage, often through fraudulent schemes run by unscrupulous brokers and enabled by lax Biden administration enforcement. The bill ends the special enrollment period for anyone claiming income between 100 and 150% of the federal poverty line at any point in time, ends auto re-enrollment without verification, and requires eligibility verification. Now let's turn to Medicaid money laundering, specifically provider taxes. States can currently tax healthcare providers and count that money towards their state share of Medicaid. The federal government then matches it. And then the states redirect those tax payments back to the same providers along with the federal funds obtained, creating a circular flow that generates more federal funds without real state spending. There is long-standing bipartisan agreement that these scams distort the program. They have resulted in a massive shift of costs from states to the federal government, diminishing states' incentives to obtain value from the program. The bill includes 3 key reforms that reduce money laundering. First, a moratorium on new or increased provider taxes. Second, a phase down of the provider tax safe harbor threshold from 6% to 3% of net patient revenue by 2032. This exact safe harbor reform was proposed by President Obama in both his 2012 and 2013 budgets. This phase down applies only in Medicaid expansion states, since in those states, $1 of laundered funds can generate $9 of federal funds, meaning that the return on money laundering and thus the associated abuses are so much greater in states that have adopted the ACA Medicaid expansion. Third, a ban on the most egregious schemes, where states tax only the providers that benefit from the spending. One state, California, used this tactic to tax only Medicaid plans and then used the federal funds obtained to expand Medicaid to illegal immigrants. OBB shut down that scheme and other state schemes like it. It's worth remembering that in 2011, then Vice President Joe Biden called these schemes a scam and supported their elimination. The Simpson-Bowles Commission also advocated their elimination around this same period. And President Obama, like I mentioned, proposed reforms on provider taxes numerous times. The OBBB also reforms state-directed payments. These are extra payments that states run through insurers to raise Medicaid reimbursement rates, often well above Medicare rates. A 2024 Biden administration rule clarified that state-directed payments can raise Medicaid payments to average commercial rates. Average commercial rates are more than 2.5 times Medicare rates. That's unacceptable. Seniors on Medicare shouldn't face access issues while hospital systems and insurers make massive profits off of the Medicaid welfare program. The OBBB fixes this. In expansion states, Medicaid payments through insurers are capped at 100% of Medicare rates. In non-expansion states, the cap is slightly higher at 110% Medicare rates. Importantly, this change just incorporates a feature from Medicaid fee-for-service to Medicaid managed care, as the government already caps fee-for-service Medicaid rates at Medicare rates. This is another 80-20 issue with voters. Voters overwhelmingly agree that Medicaid should not pay providers more than Medicare. The fourth main area, this one's simple. The OBBB mandates that only U.S. citizens and certain categories of lawful residents can receive Medicaid or ACA subsidies. It closes an Obama-era loophole that allowed people in Medicaid's waiting period to get ACA subsidies. And it reduces federal reimbursement of emergency services for unauthorized immigrants in Medicaid expansion states from 90% to what states receive for traditional enrollees. Finally, the bill includes several other important reforms. There's modest cost sharing for Medicaid expansion adults with income above the poverty line. This is similar to cost sharing requirements for exchange enrollees with the same income, and it will reduce wasteful spending. It has an expansion of health savings accounts, including allowing HSAs for all bronze and catastrophic ACA plans, and permitting people to have direct primary care arrangements and contribute to HSAs, permits telehealth coverage pre-deductible for high deductible health plans, and it includes protections for orphan drugs under the Inflation Reduction Act to preserve innovation. And one item I want to underscore is the Rural Transformation Fund. This was added to the legislation during consideration in the Senate, which is to ensure needed access to improved healthcare services for Americans in rural areas. Its success depends on smart implementation. To wrap up my overview, the OBBB was a once-in-a-generation opportunity to restore integrity, accountability, and fiscal responsibility to Medicaid and the ACA. It's now law, but the real work starts with implementation. At Paragon, we aim to ensure that these reforms are carried out effectively at the federal and state levels so that the most vulnerable are protected, taxpayers are respected, and the programs are sustainable for the long term. We have a web page dedicated to explaining the One Big Beautiful Bill, which contains a brief explaining all the health policy provisions with savings estimates from the Congressional Budget Office, a series of fact sheets that debunk myths of the legislation, and all our associated policy work. Every Wednesday, I send a note with our most recent research and analysis. If you're interested in getting added to that list or following Paragon on social media, please use the QR code on your screen to sign up. With that, the formal presentation is over. I'm going to turn it over to my colleagues and ask Ryan and Elle if you have sort of an opening comment and a few thoughts before we get into questions from the audience. And as a reminder, please, and I know we've already gotten several questions, please use the Q&A button to provide any questions that you have that you'd like us to tackle.
Thanks, Brian. I would just reemphasize that a lot of what the OBB is about is reversing some of the irresponsible administration and the explosion in spending that we saw from the Biden administration in both the exchanges and Medicaid, sort of rebalancing them to get back to the intent of the programs, which is truly serving the truly vulnerable and making sure that they're sustainable over time. So these programs will grow. There are no cuts to these programs, but they will grow in a more sustainable way so we can make sure that they're there for these vulnerable populations.
Yeah, I'm going to echo the historic nature that Brian talks about and just give another very big thank you to all of the Hill staffers and everyone else in the policy community that is on this call. I know for many of you, you did not even really understand the mechanics of Medicaid before this process, and you left that process passing some of the most monumental welfare reform that we've seen in our history. It's really important for the overall trajectory of our healthcare spending in the United States. Paragon has long said that in order to get it on a compliant path, we need to trim healthcare spending by $2 trillion. So $1.2 trillion is a really large down payment, making sure that the future of our healthcare system is sustainable. And this is a great first step. I'm really excited to get more into the details. All right, we can start with our first question here. I'll pose this to both Brian and Ryan. But what is the most important part of the bill that you would say hasn't gotten the attention that it deserves?
Ryan.
Well, Brian hit on a lot. I'm very focused on ensuring that we have innovation or continued innovation for patients. One of the things within the Inflation Reduction Act that created Medicare negotiation or price controls, depending on your perspective, was that there was a exemption for orphan drug products. That was designed to ensure that there was continued research and development into areas for conditions and diseases that affect a very small portion of the population. Unfortunately, I think there was a drafting error in the IRA that eliminated the exemption if a product got a subsequent indication, even if that subsequent indication was for an orphan disease. The OBB corrects that error by saying you can continue to get the exemption for subsequent indications as long as these subsequent indications are for orphan diseases. You will no longer get the exemption if you get a new indication for a non-orphan disease, which I believe was the original intent of the authors. And I think that that's a big win for those people that care about research and development into orphan diseases.
Brian, how about you?
And it is great. We are getting so many questions. It's going to be hard to keep up with all the questions that we're getting, but we're going to try. So my favorite provision, and I know that wasn't exactly your question, Elle, but my favorite provision is what the law does on Medicaid provider taxes. I wrote my PhD dissertation on the economics and politics of Medicaid provider taxes. And again, it's bipartisan, longstanding concern about these abuses. But we worked very hard to explain to policymakers how states and powerful healthcare providers manipulate these types of financing schemes to pervert sort of the intent of the Medicaid program. And this doesn't eliminate Medicaid provider taxes. Like I wish we could eliminate the entirety of these schemes, but it is a really good down payment on reform. And I think adopting really President Obama's exact proposal to phase down the threshold, the way that he outlined in his 2012 and 2013 budgets. That is a really important step to improve the integrity in the program and really address one of the major problems in policy over the last several decades, which is that states don't have agency in the Medicaid program anymore. If you look at over the last 15 years, the entire extra cost of the Medicaid program in real terms, like in terms of economic burden, has been borne by the federal government. As states spend less and less of their own money on Medicaid, it's the main reason why we have so much waste, fraud, and abuse in the program. So, like at Paragon, we're focused on how we can change incentives within programs to get more value from all of our spending on medical and healthcare services. And this is really changing the incentives at the state level so that states care more about the spending.
So we're getting a lot of questions right now that are related to aspects of the bill that were in the House version, but didn't make it into final passage in the Senate. So let's take a look and talk about some of the decisions of the Parliamentarian on the OBBB and what was struck. And what do you think is important, as we potentially look at a different reconciliation package or just future healthcare legislation on making sure that some of those things maybe make it back into law?
Yeah, sure, Elle. Well, there were a handful of provisions that the Parliamentarian did strike because of Byrd rules. What we don't have is a clear insight into her rationale, so we can only go by what we've heard. But some of them were the cost sharing reduction subsidy appropriations that the House bill had. That would have provided money for the cost sharing reduction subsidy, which is a second subsidy under the ACA, in addition to the premium tax credit subsidy that is designed to lower cost sharing for people below 250% of poverty. Under the ACA, that was never appropriated. There was litigation saying that it was an illegal appropriation. So in 2017, it was decided that they would stop providing the CSRs. That had the effect of raising premiums as plans reacted. They did what was known as silver loading. So to try to address that, the House bill appropriated those CSRs. It would have had the effect of probably lowering premiums by 10 to 15%. Unfortunately, the Parliamentarian did say that violated Byrd. Again, without an official recording of what her objections were, I had heard that it had to do with her belief that there was that this was too big a change to the market to do in reconciliation, which again surprises me given the fact that the COVID credits, the COVID tax credits from 2021 were done retrospectively in reconciliation in 2021. That didn't violate Byrd. The Part D Medicare program, which covers 2.5 times the number of people in the exchanges, that benefit design was changed dramatically in 2022 in the Inflation Reduction Act. And then they changed the benefit design for Part D in 2010 in reconciliation. So again, I'm just going by what I heard, but I'm not sure how that really fits with prior precedent related to market changes, especially because this was not a new policy. This was a policy that was actually in effect for 3 years, and now we were just providing an appropriation for it. Another one was the House had a prohibition on Medicaid financial participation for transgender surgeries or permanent transgender surgeries. She had said that that didn't comply with Byrd. Again, I'm not sure what the rationale was. That was strictly a limitation on funds, what the federal government will or will not pay for. A third one was the House would have said if you're an expansion state and you cover illegal immigrants in your Medicaid program with theoretically state-only money, instead of getting 90% for the expansion population, you would get 80%. That provision was also struck by the Parliamentarian, but I don't really have good insight into her rationale on why that was struck.
Awesome. Thanks, Brian. Brian, do you have anything else to add there?
I am just going to go to another set of questions, given how many that we're getting.
Yeah, well, I
Please.
will say we are getting a large influx of questions. So if it does not get answered on this webinar, feel free to send us an email afterwards. We do have them recorded and we will use them in terms of making our future products. So I'm getting a lot of questions here, kind of talking about who the Medicaid reforms are going to impact, kind of the level of waste, fraud, and abuse that's there. So this is going to be a two-part question for Brian and Ryan. First, can you guys talk about the improper enrollments that are in Medicaid, even potentially fraudulent enrollment, people that are enrolled on the rolls that should not be there? And then on top of that, after you answer that question, talking about that population, can you go into how these reforms are going to impact seniors, folks in nursing homes, et cetera, that more traditional population of Medicaid that we at Paragon think the One Big Beautiful Bill protects?
Yeah, so on the estimates of improper eligibility, so Paragon, we've estimated that for both the exchanges and for Medicaid expansion. And if you want our most recent research on the exchanges, it is a paper called The Greater Obamacare Enrollment Fraud. And Liam Sigwid has a paper on the improper enrollment in the Medicaid expansion. The issue is the incentives, again, to get back to incentives, they're all aligned for improper enrollment because the improper enrollment can drive higher subsidies. Because of Biden's COVID credits and because they made a decision not to enforce, not to verify people's income prior to enrollment, you have millions more people claiming income in a category to get a fully subsidized ACA plan than have that income. The methodology that we did to estimate this is just to compare the signups in that income category with the estimate that we got from Census Bureau survey data of the number of people in each state that would have relevant income in that category. And we estimated more than 6 million people enrolled claiming income in that category than have income in that category. And that's just not a problem of enrollee fraud. There's been numerous press reports of sophisticated fraud rings. Brokers are only getting paid when they improperly enroll people or when they enroll people in the program. They're making large monthly commissions, and insurers are have also benefited from all of this improper enrollment. On Medicaid expansion, you also have that problem. So during the course of our work, one of the stats that we put out is that on average, states get 7 times more funding from the federal government for every dollar on an expansion enrollee than a traditional enrollee. Well, that gives states enormous incentives to misclassify individuals. Those eligible under the traditional rate, where the federal government provide the state with less funding, has those eligible under the expansion. And unfortunately, that exploded too, as states just naturally respond to the incentives. And because the Biden administration didn't do audits and they didn't enforce the law. So really a large portion of the savings in this bill are from just checking eligibility to make sure that the right federal subsidy is going to states through the Medicaid program and is going to individuals on the exchanges. On the who do the Medicaid changes affect? We got a question asking about somebody's 95-year-old mother in the nursing home. That individual is not affected by the changes in the bill. If anything, those individuals in nursing homes, those who truly need Medicaid, are going to be better off because the program will become more focused on them as a result of the changes in the bill. The provider tax phase down that is occurring in expansion states, it actually leaves off nursing homes. And the reason for that, the policy reason for that, and I outlined this earlier, is the money laundering generates so much more federal funds under the expansion FMAP. Nursing home enrollees are not expansion enrollees, so they're not receiving the 9-to-1 federal match. So those taxes which, I think are all provider taxes are a problem and a shell game. But Congress decided to exempt nursing homes from the provider tax phase down.
Oops, sorry, I was on mute there, Ryan. I have a specific question for you. Were there any effects on HERSA in the One Big Beautiful Bill? We've been getting some reports that constituents have been reaching out concerning possible freezes. Could you answer that question once and for all?
Well, the thing about the One Big Beautiful Bill is it has to focus on mandatory spending programs. That's why it focused on things like Medicaid, on taxes. Discretionary appropriations aren't affected or can't be addressed in a reconciliation bill. So for people that are getting calls on how HERSA would be affected by the OBBB, HERSA is entirely funded through discretionary appropriation, so that they wouldn't have a effect from OBBB.
Awesome. Now let's kind of move the conversation over into provider taxes and SDPs. We've been getting a lot of questions talking about people getting talking points from hospital systems or large insurers talking about how the reduction in SDPs and provider taxes are going to be a large burden on the states and cause them to cut benefits or close access. Brian, what do you have to say to those talking points, and how can you succinctly push back on some of the reforms?
Yeah, I mean, the reality is that the states have shifted massive costs to the federal government over the last 15 to 20 years. And I mean, there's the Wall Street Journal had a great piece in April on hospital systems throughout the country that are making windfall profits from these much higher Medicaid payments. We refer to it as corporate welfare. So you think about it, it's the provider taxes that are the fuel for all of this increased federal money that's coming into the state. And then the payouts have been going out through these state-directed payments up to average commercial rates. And so this is a problem in many parts of the country where the hospital systems go to the states and are like, look, it's a win-win. It's all federal tax dollars. So you can relieve the state of any actual burden from paying for this with taxes on state residents. You just siphon the cost off to federal taxpayers, and it's a way that you can direct all of these resources into the hospital systems. All of that spending has a cost. That adds to federal deficits. It adds to federal debt. It is contributing to higher interest rates. It contributes to inflation. And these are decisions like if a state was spending its own money, would it be paying for Medicaid recipients 2 to 3 times what it pays for Medicare recipients? There's no way. So these reforms are about reforming the partnership and taking Medicaid back to actually a true partnership between the federal government and states. And more needs to be done. This is just sort of it's a necessary like set of steps, but there's still more that needs to be done to ensure that we're going to get more value from this program. But I do give Congress a lot of kudos for being able to overcome the lobbying power of big hospital systems and big health insurers that didn't want these massive subsidies to be reduced, and that just wanted them to continue in perpetuity. I also give Dr. Oz a lot of credit. Dr. Oz at CMS did a lot of work explaining the abuses with provider taxes and state-directed payments, and how these Medicaid funds were not going to the truly vulnerable. They were going to profit the already rich.
Yeah, well, at Brian, at Paragon, we often talk about how provider taxes are the fuel to the Medicaid money laundering machine, that they really are what allows it to kind of take off and go. So we did get a previous question, saying, is this it for the Medicaid money laundering machine, or are there more schemes and gimmicks out there that folks have been abusing and might even continue to abuse after the One Big Beautiful Bill?
Hey, Ryan, were you going to interject before I
I
take
was
that?
just going to say one thing. When you tie the Medicaid rates to average commercial rates, there's also evidence that people in the commercial market pay much higher premiums. And I think the state treasurer of North Carolina wrote a letter to CMS in 2023 voicing that very concern. I think the other thing is the way that a lot of these payments were structured, the assistance actually didn't reach the facilities that were truly in need financially. Most of the assistance would go to wealthier entities. So one of the things the OBB does is says, okay, well, let's stop flooding the zone, providing more money to, those entities that are stable financially, and let's target assistance through the Rural Health Transformation Fund to those entities that truly need more assistance.
Hey, Ryan, that's a great point. We have evidence, and one of Paragon's public advisors, G. Bai, has published on how tying Medicaid payments to average commercial rates also creates an incentive for average commercial rates to increase. So it's bad for people with employer-based plans as well from paying higher premiums. Elle, to your question, there are still ways that states can game the Medicaid program. There's something called an intergovernmental transfer, which is similar to a provider tax, but it involves a unit of like a academic medical center, a university hospital, county-owned uh, nursing home that transfers money to the state that the state then uses back on those providers and then leverages the federal reimbursements. So restrictions on intergovernmental transfers are certainly something that the Trump administration should be looking at doing to really tighten the fiscal integrity within the program.
Awesome. So let's move on to another aspect of this fear mongering. And Ryan, I'm going to give this one to you. But there's a lot of fear mongering going around about the community engagement requirement, how that's going to be implemented in the states, the potential administrative burden, the lack of tech systems both on the state and the county level. Can we talk about that? And can you also make sure that you're hitting on some of these common sense exemptions, whether that be for folks that work in the gig economy, maybe folks that are business owners? What does this look like for them, and how do you counteract some of that fear mongering that's really tied around that community engagement requirement?
Well, one of the things I find interesting is people acting like we haven't had community engagement requirements in our welfare programs before. This has been national policy for the supplemental nutrition program going back to the mid 1990s. Some people have pointed to, Brian mentioned Arkansas in 2018. And what was happening there were states were trying to implement work requirements through waivers, so sort of one off on their own. So first, the difference is going to be now we have a national policy where the central CMS can help states with some of these administrative issues. They will be tasked under the OBB to issue an interim final rule by June 1st, 2026 that lays out a lot of the answers to the questions that you're asking, Elle. Additionally, the bill provides $200 million to states in grants to help implement the community engagement requirements and systems necessary to do that. And as Brian mentioned, technology has changed so dramatically since 2018. And so our ability to transfer information, use AI is dramatically different than it was 7 or 8 years ago. As far as you talk about exemptions, as Brian mentioned, this applies to working age adults that are able-bodied that do not have children 14 or below 14. For those people that may have special circumstances, let's say they're a caregiver, there's exemptions for caregivers if you're taking care of a family member that has a disability. There are exemptions for people that are medically frail. I've heard questions about, well, if you're a seasonal worker, you may only be working part of the time. There's language specifically addressing how seasonal workers can demonstrate that they are complying with the community engagement requirement. So there will be implementation questions that CMS is working through. I think CMS should provide a model to states that states can use if they want. I think that would help. And again, that would be very different than what happened in 2017 and 2018.
Let me talk about the state implementation for a second because I want to promote something that Paragon is doing. We're going to launch a state health reform initiative later this year. And the key focus near term on that initiative is going to be state implementation of the key provisions of the One Big Beautiful Bill pertaining to Medicaid, specifically how to implement the community engagement requirements and what states steps should take to reduce the improper payments in their program. Previous Paragon research, and we estimate nationally the Medicaid improper payment rate is 25%. The federal government has been historically really almost criminally negligent at enforcing good program integrity in the Medicaid program. But this bill does give CMS more power to make recoveries when states have high improper payment rates. So states are going to have incentives to get those improper payment rates down. The large improper payment rates are really driven by erroneous eligibility determinations. So states are going to have increased incentives to make sure that they are ensuring that only eligible people are on the program and that they're effectively implementing the work and community engagement requirements.
I had one other thing. You kind of alluded to it before, Brian, but CMS back in July, after the OBB passed, came out and said they found 1.2 million people were enrolled in Medicaid in multiple states. That's another thing that the OBB addressed, is saying states have to actually take proactive steps to make sure that people aren't enrolled in another state when they enroll in their Medicaid program. Because when you have Medicaid managed care, money is going out the door regardless of whether or not an individual is obtaining services or not. They also found another 1.6 million people were enrolled in Medicaid and a subsidized exchange plan at the same time. And so the provisions of OBB and the steps that CMS are taking should save about $14 billion annually, or over $140 billion over 10 years, which I think is a very big step.
Awesome. Yeah, I agree. We're getting a lot of questions here specifically about hospitals and how states can work with their hospitals to make sure that they get access to that rural health transformation fund. And then most importantly, that we can really insulate that rural health transformation fund from turning into a slush fund. So what do you guys have to say about, coordinating with states, making sure that those funds are being used appropriately? And then also taking a second look on this through a different veil, which is for states that passed midnight expansions of either their provider taxes, like Wisconsin going from 1.5% to 6% the night before the bill passes, or states that submitted preprints on state-directed payments to CMS. What do you have to say about the implication of those additional funds and really making sure that some of these delayed Medicaid provisions as they take place are also taken into account with some of these targeted funds in the Rural Health Transformation Fund?
Well, that's a lot with that question. I'd say Rural Hospital Transformation Fund, there's a lot of work that has to be done this year. So if you are in a state, there's going to be information coming out of CMS, but we really view this as an opportunity to better use public funds rather than just flood so many hospital systems with money through these money laundering schemes that they don't need, that just juice their profits and that increase executive compensation to target funds to transform rural healthcare. I think it's an important opportunity over the next coming years. And I forgot the second part of your question now.
No, that's okay. We were just talking about how, there were some states that last minute tried to get in with CMS on provider
With
tax
those
and
states,
SDT.
I mean, the big decision for CMS is how they're going to deal with existing state-directed payment arrangements, and the process for having existing state-directed payments come into compliance with the Medicare rules. That is a big area that we're going to be watching with implementation, that we expect there's going to be some guidance, a lot of guidance coming out from CMS on. I want to pivot to the parts of the healthcare a government healthcare policy that we still need to reform, because clearly, there was this bill had a had a certain focus, but there were no Medicare changes in the bill. So let me ask Ryan to go first and talk about parts of policy that still need reform, and that we're focused on at Paragon, and then I will do cleanup there.
Yeah, I'm going to do two, Brian. One is Paragon has done a lot of work on the issue of site neutrality for Medicare payments. That means we shouldn't pay one site more than another for the exact same service. If you do that, we can reduce both program cost and beneficiary cost sharing. We can also inject greater competition into healthcare if more people are able to perform those types of services at the same sort of payment parity rate. The second thing I'd say is one that was in the House bill, and frankly, I'm not sure why the minority wanted to object to its inclusion, and that was the appropriation of cost sharing reduction subsidies. It would reduce premiums. It was something that came originally from the ACA, and if it wasn't from a sort of a legislative drafting defect from the ACA, they would have continued. So I'm really not sure about that one. That seemed to me to be a bipartisan, logical, common sense provision, and hopefully they will look at that again.
Yeah, so within Medicaid, and we got some questions about the 90% FMAP, and if you follow Paragon's work, you know that we spent a lot of time arguing that Congress should reduce the 90% FMAP, that it doesn't make any sense for the federal government to pay states much more in federal money when they spend on the able-bodied working age adults than on traditional enrollees in the program. That disparity is immoral in our view, and it's bad economic health policy, and those rates should be brought into equity. The federal government should not discriminate against the most vulnerable. And that is something that we will continue to work on. I mean, we did a major policy paper last year where we estimated reducing the 90% federal reimbursement to what states get for other enrollees, and then transitioning about half of enrollees into the exchanges, which we think would significantly reduce federal deficits and reduce Medicaid and expand coverage in the exchanges. 340B is a program that we are, very critical of its growth, its distortions throughout the healthcare sector. And really, you could fit it into this category of there's just a bunch of subsidy programs for hospitals that don't make sense, and that there should be some rationality put around them. And then I would say the last one that we've spent a lot of time on is Medicare Advantage reform. Well, we think MA provides seniors choice, and there's a lot of advantages to MA. We wrote a paper last year about how MA could be reformed to address problems with the benchmark setting, with the risk adjustment program, with the quality bonus payments. And we think there are bipartisan opportunities around MA reform. So we'll plan on continuing to work on all of those areas.
Yeah, Brian, this bill, the One Big Beautiful Bill, really tackles, federal health spending on Medicaid and just kind of overall. And when we start to look at policies that really start to get at increased healthcare costs, making them better for the consumer, what is next on the list for, expanding different types of health insurance options to consumers that have lower cost options, making sure that they have more healthcare freedom through things like HSAs? What do you think is next up for Congress in that, guys?
Yeah, so I think there's action that the administration can take, irrespective of Congress, to open up options. So one of the things that I worked on in term one was expansion of different affordable options for small businesses and individuals. So short-term health insurance plans. The Biden administration restricted those, which reduces Americans' freedom to finance healthcare the way that works best for them. the Trump administration should rescind the Biden administration restrictions and go back to what the policy was in President Trump's first term, allowing small businesses to join together through association health plans. That's another area that Republicans have been supportive of. There is a policy problem with small businesses increasingly not offering coverage that has significantly worsened because of Obamacare. And then we've got the individual coverage health reimbursement arrangements, which is a way that employers can offer coverage where they give a contribution that workers take and buy a plan in the individual market rather than select the plan for all the enrollees. We think there's a way that the administration or Congress could build off of ICRAs to make that a more robust option for employers and employees.
One thing in follow-up, Brian, the one big beautiful bill did expand HSA access in two major important ways. One, you can now use your HSA for direct primary care, and two, if you get coverage in the exchange, you can get an HSA if you have a bronze or catastrophic plan.
Yeah, thanks, Ryan. Okay, so now we're going to transition just a little bit into talking about the ACA, maybe some of the ACA provisions within the OBB. We're getting a lot of questions here around, fraudulent enrollment, on potential the conversation that Congress is going to have about extending the enhanced premium tax credits. Paragon has done extensive research not only into the financial harm on the federal government and the American taxpayer that this fraud has had, but also the harm that it has on enrollees that have been enrolled without their consent and their tax penalties, and also the physical impacts on their health that comes from having their plans switched due to this. A lot of this we talk about how this is because of the Biden administration. And so what is next after the program integrity rule and after the one big beautiful bill and strengthening the ACA to make sure that unscrupulous brokers and the corporate welfare that we provide to insurance companies aren't just driving up premiums but really trying to better healthcare access.
Yeah, so and you have a great piece, Elle, that I should recommend from a few weeks ago, where you detailed about a dozen stories of people that have been harmed from getting enrolled into plans without their consent. The program was turned into the wild, wild west and just became a den of waste, fraud, and abuse. And one of the most important initial health policy actions of the Trump administration was an ACA program integrity rule to undo the reckless policies of the Biden administration. You have to check if you have advanced subsidies to insurers that are based off of income. You can't just rely on self-attested income. You have to actually check that the income that the applicant or the broker puts on the form prior to those large subsidy payments going to health insurers. This year, almost half of the enrollees in the exchanges took no action. They were just moved from a plan in 2024 to another plan in 2025. It's called automatic re-enrollment. What that has done is just perpetuate improper and fraudulent enrollment determinations over time. We have seen brokers quoted that have said, that have taken very nefarious tactics to enroll people. They've said half of these people that we've enrolled have no idea that they were signing up for health insurance coverage. They were manipulated by advertisements of free cash or gift cards to call a number. They got signed up for health insurance. In my home state of Florida, we estimate there's 5 times as many enrollees in these fully subsidized plans that are eligible. And in 15 states overall, there's at least twice as many people signed up in these plans that are fully subsidized that are eligible. So it's really a program integrity crisis in the exchanges that the Trump administration confronted. Combination of those enhanced COVID subsidies, which are expiring after 2025, as well as the Biden administration just pursuing an enrollment at any cost strategy. Importantly, the Trump administration is also taking actions to try to lower premiums. So these things that restrict people's ability to game the system, they lower premiums. Some of the flexibilities around plan design, lower premiums. So that program integrity rule is projected to lower gross premiums by up to 5%. Ryan mentioned the CSR appropriation. CSR appropriation is actually Republicans going back to the original way Obamacare was designed. Rather than being like any type of sabotage, it is about Obamacare working better and without this perversion where the subsidies have been jacked up because of the so-called silver loading. So I would love to see Congress later this year enact a CSR appropriation and lower premiums. And it's a double benefit. You lower premiums and you lower federal deficits because the subsidy is tied to that premium. So the subsidy comes down as well.
Brian, any closing thoughts on that?
Well, I would just say the introduction of $0 plans was really what fueled a lot of the explosion in fraud, with what Brian mentioned in terms of lack of eligibility verification. When an unscrupulous broker can sign someone up for a plan, that person doesn't have to pay any contribution. The plans just get paid a premium every month from the government, regardless of whether or not that person knew they were signed up or not. So I think that was really what helped fuel the explosion in ACA fraud.
Yeah, I agree. Well, that brings us to the end of our webinar today. I want to thank you all for joining us. We peaked at over 300 attendees, which is really, really exciting. It's also exciting to announce that this is just the beginning of our virtual event series. Over the next couple of months, we will be having several of these, including an event specifically on ACA fraud and the ACA subsidies. So be on the lookout for that from us. If your specific question did not get answered today, our contact information can be found on our website. Also, feel free to reach out to us on social media. Again, we really appreciate you keeping up with Paragon's work. All of your smart questions and all of your insights help make us better researchers and help us make better products. So we are excited to keep working with you and really get into the nitty-gritty of future healthcare reform. Brian and Ryan, any closing thoughts today?
Thanks everybody for your participation. We realize that the One Big Beautiful Bill is transformative. There's a lot of misinformation floating out there about the legislation, and that is promoted by, in many parts, the healthcare industry that just doesn't want the status quo policies and the large federal subsidies to be reduced. So we feel one of our most important values right now is to provide accurate information about the legislation. So we have a dedicated webpage on our website that is just for the One Big Beautiful Bill, and where we're going through and explaining key aspects of the legislation and debunking a lot of the myths that are spreading. And again, this is just the first start. It's an important start. The legislation needed to get enacted. There's now important work to do at the federal and state levels. And we are here to help and provide information and education at both the federal and state levels, and then to think more broadly in terms of reforms that meet Paragon's mission of empowering patients and reforming government.
Brian, anything from you?
I appreciate everyone taking time out in August to come to this. Thank you.
Well, we hope you all have a great day.
Thanks, everyone.